Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. How are you?
Good. Some more live video content for the upper hand.
Oh my God. I mean, what an opportunity for us. Plus, we get to see each other again.
Absolutely, absolutely. Nothing like computer screen contact.
Absolutely. I'm at the Shriners Hospital today. Where are you?
I'm at our South County facility. Just had a day of combination of peripheral nerve and bread and butter hand surgery and some wide awake stuff and some regular old general anesthesia. So anything fun at the Shrine today?
Yeah, we had a good day. We had a lot of interesting cases, some pretty uncommon congenital stuff with bread and butter mixed in. Yeah, it was a good day for sure. We are finishing our last case, so also timely.
Ah, yes. And so we have a journal club to talk about today. We've discussed three really nice articles from a variety of journals in our WashU Hand Service Journal Club yesterday. So why don't we kick things off talking about this article from Virginia Tech? So this is an article in JBJS that it's called "Modified Wide Awake Local Anesthesia No Tourniquet Surgical Procedures Do Not Impair Driving Fitness." So any thoughts on this one?
Yeah, maybe we should briefly just talk about what they did, which is essentially, to keep it simple, these were not real patients, but these were patients that were volunteered and numbing medicine was applied, and then they sent them home like they might with a patient who was treated with a wide awake surgery, driving themselves home with the idea of, do these patients perform safely on the road? And the short answer is they do. And basically they showed non-inferiority to baseline driving.
Yeah, so
And
they blocked them. They had him do a driving test first and then blocked them and then have him do the test again, right?
exactly, which, there's lots of ways to be critical of how they went about this. But the bottom line is, I think it was a reasonable study that was very focused and answers a pertinent question to at least some of us.
I've already found it to be useful in practice to corroborate what is a widely held belief that this is a safe practice in terms of patients driving themselves to and from for things like carpals and triggers that are done volant. And honestly, it's been good for conversation fodder during the wide awake surgeries with patients, asking them if they drove themselves here and back and talking about a driving test and all that stuff. And, so it makes for good conversation. Sometimes you're reaching for conversation during the wide awake cases.
That's absolutely right. And this doesn't mean that the older patient who may not be the strongest driver pre-surgery should still drive themselves home. But I think for many of our patients, it makes me feel a little more comfortable. That's all. And I liked it for that reason.
Yeah, and I think you made some really good points in the journal club yesterday. It's a great example of a definable project with a good research question that is practical and can inform practice. And then secondarily, it's a good example of using your institution's resources. So this is a really interesting collaboration between their clinical side and then the Transportation Institute at Virginia Tech, which not every place has. So it's a pretty cool collaboration.
Yeah, and that's exactly right. I think part of research is understanding what resources you have at your disposal. And that can vary from having stats support to having a driving institute and everything in between. And leveraging those potential collaborations is just so important because succeeding in this world of publishing is not easy. And so taking a different tact on study design or again using your resources, it's just a no-brainer.
Yeah, I find it difficult to predict what's going to get through the peer review process. There are sometimes I review articles that I think are great and I recommend that they get accepted, and then I found one out today that got rejected. But fortunately for these authors, they did a really nice job getting through the process with a question I think that will be practical and useful to a lot of people. So kudos to them.
Yeah, totally agree. And I think all of my papers are great, and not all and all of them don't get accepted. I don't understand why that is.
Yeah, no, my hit rate's been all over the map. So I think like
Yes,
anybody, you got to be a volume shooter.
that is true. All right, let's move on. So let's go. to a mixed method study on the influence of cost information on treatment choice. And this is from our friend at Stanford, Rob Kamal, and his group. And it is a really interesting concept, which basically they were testing the hypothesis that exposure to societal cost information does not affect choice of treatment for carpal tunnel syndrome. And they had 304 participants using this Amazon Mechanical Turk platform to complete a survey. So what do you think?
Well, I think they probably went into this with the hypothesis that the null hypothesis would be proven true, that there probably wouldn't be a difference in how people thought about things based on societal cost information. But that's not what they found. They found that when patients were exposed to information about surgery, that they actually picked surgery, in terms of the therapy that they would prefer. Now, it's important to note that they were given societal cost information. So they were told that there would be no out-of-pocket cost to them from surgery. So I think the way that the research question is shaped may influence the folks that were filling out the survey. And it's really important to note that these were not patients. These were people on the Amazon Mechanical Turk platform that get paid to do surveys. And there are some strengths to using that approach, but it is important to realize that this is not a particular patient population. And I think there is a difference between participants and patients, particularly for this kind of study.
Yeah, it's that classic concept of what's good, what's for the greater good, and what's good for me. And I would say most of us have trouble putting aside the me when it's actually a choice that matters to me. So hypothetically, I'm all about the greater good. But when it comes to my care and also my out-of-pocket expense, then it's a very different question. So this is a little bit of a tough one. Again, I love the concept, and it does at least start the conversation or further the conversation that about cost and cost information, and that's just incredibly important. But I don't know about this.
Yeah, I'll say that, it's the classic behavioral economics trap of moral hazard. What do you do when it's not your money on the line? And I think that people will decide differently, and also people will respond to a survey differently than if they're faced with an actual situation themselves. I think that the group here, Rob has done a lot of work in this area, and I think this is one piece of a larger puzzle for him, and it's difficult to see its importance when published in isolation, but probably within the greater overall puzzle, this together with the rest of the body of work will make a lot of sense, I hope.
I think that's right, and certainly I have a great deal of respect for what Rob has done and will continue to do, and I think you're right. I think it probably is one piece of of the puzzle.
So we have one more paper that was from Plastic and Reconstructive Surgery, published earlier this month, and that's from the group largely at the Mayo Clinic. Obviously, Brent DeGeorge has moved on to a different location, and the second author is one of our partners, David Brogan, and the senior author is Alex Shin. So this was, let me pull up the title of the paper here. This was the relationship of volar plate position and flexor tendon rupture. Ooh, a provocative question in the title. Should we question the validity of the Soong classification? So what do you think of this paper, Chuck? What did they do here?
Well, they basically looked at their own population of patients, and they had 659 distal radius fractures were reviewed, and they found a very small incidence of isolated flexor tendinopathy and tendon rupture. So that's part of the problem. But the Soong classification basically says, your plate should be dorsal to that critical line volarly. And if the plate touches or is volar to that line, that's a higher risk. And if the plate is distal, that's a higher risk. So it's kind of A, B, and C, or 1, 2, and 3. I don't remember. And essentially, they concluded that this classification is not the be-all and end-all. It's just a tough study because for any study, again, you have to know what you have. And they looked at a huge number of patients, but the reality is the incidence of complications was just incredibly low.
Yeah, so 659 fractures in 648 patients, and they only had 2 reported cases of tendon rupture, which, I mean, kudos to them. That's an incredibly nice, very low complication rate, which says a lot about the surgical team there, but it just makes it harder to really draw conclusions. And I think that when taken in the context of other work that's been published in terms of when the flexor tendons are, adherent to the plates and when they're, at risk, this makes sense. I don't think the SUM classification is the end all be all, but I do think it's useful. I don't think you can throw it out the window right now. But there are other studies showing that when you have residual sagittal tilt that remains at neutral or even dorsal, the tendons get irritated in a different position than when there's an anatomic volar tilt of the distal radius with a plate at a good position.
Right. Look, I love the concept of questioning everything, right? And clearly the authors had a preconceived notion that there were additional factors. I just don't think they had the numbers to really convince the readers that that is true, even though we still probably believe that that is true.
So are you throwing out the SUM classification or are you still using it?
I'll be honest, I don't use it regularly at all, but I use the principles, and that is stay proximal to the watershed line and, have a plate and plate choice matters at least to some degree. I'm actually a believer that most plates are pretty similar, but a thinner plate that fits the radius well is really important, and keep it proximal when at all possible.
I think that, the principles of trying to endeavor for, a better reduction when you can without jeopardizing, you only get so many passes in the bone, obviously, and in some of these patients, you can't rely on the plate to act as a reliable reduction aid in the osteoporotic patient, but there are ways to endeavor to get a better reduction from the beginning, and maybe it does make a difference. So I think that there are some pearls there, but, it just needs to be fleshed out a little bit more.
Perfect. Love it.
Well, till next month when we have 3 more articles to review.
I love it. Good to see you. Have a good evening.
All right. Nice seeing you. Talk to you later.
All right.